Right. Well, hello, everyone. I'm Aubrey Rhodes, and I have the privilege of serving as LCRF's Executive Director. Our mission here at LCRF is to fund research for the prevention, diagnosis, treatment, and ultimately the cure of lung cancer. Research is our middle name, and funding research is where we focus most of our energy. Research is only as good, though, as the informed patient. And so we have these sorts of talks where we really can bring the latest in research to people living with lung cancer. So today, specifically, we're going to be talking about women and lung cancer, and we'll be discussing the unique ways that women experience lung cancer. So before we get started, I just want to remind everyone to stay on mute. The chat is open, so feel free to introduce yourself there. You can also ask questions. We will try to get to everyone's questions. We do request that no one asks for medical advice or shares anything too personal. We do try to make sure that we are covering kind of broad topics. And then I will also share that the captions are enabled. So both in English and Spanish, you can turn those off in your Zoom settings. So if you want to do that, go right ahead. Before we turn it over to our moderator, Dr. Preeshagul, I would like to introduce an extra special guest, Angela Morabito, who is a research assistant at the Florez Lab. She's going to take a few minutes to talk a little bit with us about her Hear Her campaign and the importance of this event in May for Women's Health Month. Angela, I'll turn it over to you.
Oh, thank you, Aubrey. Thank you so much. First of all, I know that Dr. Flores and I are very humbled to be here. Like Aubrey has kindly said, I'm Angela. I'm one of the research assistants on Dr. Flores' team here at the Flores Lab. And a little bit about the Flores Lab. We are a research lab here at Dana-Farber, and we are really keyed in on advancing research in early diagnostics, targeted therapy, and health disparities research, specifically looking at the survivorship characteristics faced by historically underrepresented communities like women and young adults. And I've been having the great privilege of almost a year now to be running the Hear Her campaign with Dr. Flores, and we're just so excited to bring it here and present it to you all today. So the Hear Her campaign, I actually have the card here that is kind of blurred out for some reason. I can't really show it. Let me see if I can just take it off. I can't. Oh, here we go. Kind of. But here's the pin a little bit. Hear Her started here between Dr. Flores and I and members of the Flores Lab. As unfortunately, we've seen a lot in clinic that more and more women are experiencing delays in diagnosis. And even the women online, now that Hear Her has been almost a year old, we have seen that women have shared experiences of being dismissed by healthcare providers or being misdiagnosed, and this unfortunately can lead to further delays in lung cancer care and outcomes. And with Hear Her, we really want a call to action campaign on social media. So it is a little information card with the infamous Hear Her pin, a little along with the butterflies. And with this campaign, we've really invited women, healthcare providers, caregivers, anyone who's very interested on sharing over social media with the hashtag Hear Her. And we invite anyone to share videos, photos, a picture of the pin over any social media platform. And our goal is really to just amplify your experiences and really have you heard by the members of the medical community over social media. And we are continuing this now in Women's Health Month. We started back in November of last year with Lung Cancer Awareness Month, and now we've come back, and we're just really excited to be here. We have made it much bigger. It is now across 7 different countries, almost over 2,000 pins and more. And we're just so grateful and humbled that this campaign has gotten as big as it has. And thank you so much for having us here. As far as like information, if you would love to get your pin, we would love to send you one. Please I know there is an email at the end of this event where you can kind of reach out with your personal information. I would just need your name, your address, and how many pens you would love. And as you can also follow us on social media. So if you have social media, Twitter, Instagram, Blue Sky. I know Dr. Flores also has LinkedIn, so if you want to reach out through there, we are so happy to send you one. And I know that our information will be in that email as well. Let me see anything else. You can also, follow us anywhere to get that pin. But we are very thankful to be here. We are very thankful to have you all a part of hashtag Hear Her, and we're so glad to have you all here. And thank you so much. But I would love to pass it over to our moderator now, Dr. Preeshagul, who is the assistant attending the thoracic oncology service at Memorial Sloan Kettering Cancer Center and the head moderator of this event.
Thank you so much, Angela, for the kind introduction. And I love hearing everything about the Florez Lab and how you are just taking over this space. So without further ado, I am going to introduce someone that is so dear to me, a great friend, someone I aspire to be like, look up to, and just thrilled to have her here, Dr. Florez. So, Dr. Flores is an associate director of the Cancer Care Equity Program and a thoracic medical oncologist at the Dana-Farber Brigham Cancer Center, as well as a member of the faculty at Harvard Medical School. In 2022, Dr. Flores also became the first Latina to hold an associate editor position in oncology at the new associate editor for diversity, equity, and inclusion at JAMA Oncology Journal. Dr. Flores' clinical interests include targeted therapy for lung cancer and the care of women with lung cancer, including their unique aspects of cancer survivorship. She is the principal investigator of the SHAL study, which stands for Sexual Health Assessment in Women with Lung Cancer. This is the largest study to date evaluating sexual dysfunction in women with lung cancer. I feel like I could go on and on about the incredible accolades and everything that this fantastic physician is accomplished and will be accomplishing going forward. But I just want to dive in and let's hear from her. Dr. Flores, would you like to say a quick hello to everybody?
Yes, the first thing is I'm just incredible proud of Angela. I don't have children, but I think my heart is so full. So thank you to the Lung Cancer Research Foundation to give her a platform. She has certainly changed. She just connects with patients, and it's true honor to help people growth. And a title that I didn't was asking for, but life gave me, and also the caregiver of my mom. And that has allowed me to evolve over time about the needs of patients, not only in those 30 minutes you have with your doctor, but about the survivorship from the other side as being I know the oldest, but I'm the daughter. You all have one in your family, like the one that plans, organizes, makes the schedules, and all of that. And I think that's my biggest title, is to be the caregiver of my parents. At this point, I've been doing this with the Lung Cancer Research Foundation since 2021. And my mom was diagnosed in 2023, and my dad was diagnosed in 2022 was my mom, and 2023 was my dad. So through the years, I continue to come and to finish about Hear Her. So there are two types of pins. Ones have flowers or roses, and those are for hope, that we eliminate or understand lung cancer in women better. And the butterflies that many people have, for some reason, they're the favorite one, right, Angela? People love the butterfly, is to honor the women that we have lost to lung cancer, but we continue to work for them and fight for them and study the disease, because lung cancer is a disease of women. And I will go dying kicking and screaming that until my last breath, that lung cancer is a disease of women, and that we need to stop gaslighting and using that word, or women when they present with symptoms, and no attributing it to anxiety. We actually have some preliminary unpublished data that shows that the number one misattribution of lung cancer symptoms in women is actually anxiety. And this came from the lead study in our own patients. So that connotation and anecdotal experience of our patients now has been shown through our study that we hope to present at our conference, in which it is, I have a patient that has a hat that says it turned out it was an anxiety. So happy to be here.
Well, thank you for that. And thank you to everyone that's taken time on this rainy Wednesday. It's super rainy here. I don't know if it's gross where you are.
It was sunny in Boston for the first time. What? We have better weather than New York?
Wow.
God, the Celtics and the Knicks today. So I'm going to leave it there.
Yes.
No, I don't know. You're in New York. I don't know if I want you to cross the fingers.
All right, we'll play nice. We'll play nice. So anyways, I'm thrilled to be here with you, Dr. Flores, and we have a lot to talk about today. I am just going to kind of give a high-level overview of the topics, but I really want this to be conversational, as it always is between us. And feel free to put questions in the chat that you have, and we'll definitely have time for a Q&A afterwards. We want this to be lively and interactive, and we want to hear from you, so please don't be shy. So today what we're going to be talking about is just an overview of sexual health, intimacy, and body image. We're going to talk about how your sex drive may change a little bit over time and as you get diagnosed and while you're on different therapies. We're going to highlight fertility preservation and how this should be front of mind. Talk about how to interact with your partner, about intimacy. We're going to be talking about weight changes that happen from treatment and how that may affect your body image. We'll also talk about something that I think is so adorably coined, grandma's treatments, that Dr. Flores has tons of. I wrote down so many last time we had this, and I've added so many to my armamentarium, but hoping to hear more. We'll touch upon mental health and integrated medicine, and of course, any other topic that may come up. So, Dr. Flores, maybe just as an overview, could you talk to us a little bit about sexual health and intimacy, and maybe give an overview about your shawl study?
Yeah. So I think there's a relationship between intimacy, sexual health, and body image. They shouldn't be separated, and sexuality in women is very complex. I will start all the statements saying that it is okay to not feel like you want to be intimate when you are dealing with synergy treatment. It is not mandatory, it's not a duty. And everything starts within self, right? So the first homework that our attendees have, and you know this homework, what it is. All of you here, this is homework. You're gonna get naked in front of the mirror by yourself, and you're gonna look at your new body after your cancer treatments, and you're gonna see then as a stronger body as a consequence of the treatment. That's related to sexual health. We're gonna go there. So understanding the beauty of your body, that whatever society says is supposed to look, that doesn't apply to a patient with cancer, that doesn't apply to a partner with cancer. And those scars from surgery, radiation, from skin rashes from the treatments, those make you stronger and why you're here. So as women, we have been told over and over again to don't like our body, right? So this is the first step. Everybody's gonna get naked tonight or this afternoon and look at your body and say, I like I'm gonna use my example and I'm gonna be very graphic. I have one nipple that looks to the other side, but that's okay because if I get attacked on the side, I have somebody watching for me, right? So on the front and on the side. And I'm going that straightforward because we have to recognize the beauty of our hair. I used to change my hair all the time and straighten it out to fit in. For what? This is what it comes out. It's great. I can wake up and go. So everybody starts looking at your body and accepting your body. How is that related with intimacy and sex life? Sex life in women, it starts with ourselves first. Cancer changes everything. It changes our serotonin, our dopamine, our skin, and tyrosine kinase inhibitors, which is osimertinib, alectinib, all of that, dry all mucous membranes. And when I talk about all of them, I talk about all of them. Vulva dryness, vaginal dryness, mouth dryness, and all of that is related to sexual health. So after you got naked, I would like to ask our attendees if they feel comfortable, but I would encourage it, to get a mirror and see how are things down there. Because we're often told by society that, you don't look down there, but things have changed with treatment. And I told my own mother after she finished chemo immunotherapy and say, have you look at your chassis? That's how we joke about it. Go and look at your chassis. If you go to the mechanics, you need to know what is going on, right? So it's a new discovery of sexual health. It's a discovery of sexual health with your new body. So what do you like? Self-stimulation is a beautiful thing, and it only requires the patient, right? Why orgasms have been associated with less need for pain control, less need for benzodiazepines, better quality of life, less anxiety, and let's all be very honest, better skin. And how much money did we pay for better skin, right? Like this foundation is like $70. So orgasms are free. So getting to see what you like now, what you don't like is the first step for sexual health. Because unfortunately, 77% of women with lung cancer in any part of their journey have moderate to severe sexual dysfunction. 77%. So it's more likely that you will have some type of sexual dysfunction. And women's sexuality is complex. So it starts with us, our comfort level, and self-stimulation. It doesn't have to be penetration. It can be just clitoral stimulation. And thanks to Amazon, you can get it shipped to your house in a box that nobody knows what it is. There are many toys. We just get a talk at the Hub Summit, and I travel with 11 toys. Every time I get to talk in the Hub Summit, TSA looks at me weird because I go there and I come back with nothing. But there are many toys that can be used. Not everything is about penetration. That is incorrect. Penetration is only 10 to 15% of sexual activity. So self-stimulation is very important, and self appreciation of the new body. That's how sexual health starts in lung cancer for women, in my opinion. And I'm very open about this subject. I talk to my mom about it because immunotherapy also drives your mucous membranes.
Well, I thank you for that overview. I think it's totally true. And I think something to be said is that we don't talk about this enough. We don't at all. And it takes a lot of time. And I think, you know, sensitivity and building a relationship with your patient for them to maybe feel comfortable to open up about this. But I think something that you've taught me is that maybe we need to be the ones to broach the topic first so that they feel like it's safe to talk about it and they're not bringing it up after a year struggling.
Yeah, and also it can be written. I told my patients, you don't feel comfortable? Send me a patient message. Because with technology, let's all be very honest, you feel more comfortable typing it. So they type it, and my nurse knows that I'm the one calling, not the nurse. Like there's a skip there. If it's a sexual health, I'm calling. And it evolves. The sexual care needs evolve. At the beginning, it's all hands on deck. The last thing you're thinking is about sex. But now our patients are living longer. My mom had her 3rd-year anniversary with oligometastatic lung cancer, April 28th of this year. So my mom has 3 years. So are we expecting that she would be celibate or that she will no self-stimulate for 3 years? Come on, let's all be very honest, right? So it changes. It goes by phases. Relationships also get affected by cancer. So the needs, the sexual needs, we evolve. I don't talk during the first visit. It's not patients thinking about that. But as things are evolving, on Monday, I had a patient that just celebrated her 12th year with metastatic lung cancer. So are we asking her to know self-stimulate, to know have fun, to don't feel sexy? Because it's not only about sexuality, it's about feeling sexy, going to Victoria's Secret and being okay buying that push-up bra. Because it's who you are, and or hair affects your attitude, right? You and I have a lot of hair. You, Liz, you and I have a lot of hair, and when this thing is not under control, the day can be difficult, right? So I just came from the Dominican, and I forgot how much my hair doesn't like the humidity. So encourage your women to remember who they are, and that cancer is not what defined them. Cancer is something that happens to them, and now they're stronger than they were before. And that's and Angela's here as a weakness. I like my ladies to like, let's do makeup, let's have fun. And you don't do it for other people. That's the most important thing we tell our patients. You do it for you because you feel better. And there are also days, and sometimes days I'm in the lab, that people probably question if I actually work in the building. Because I don't feel good, I don't look good, and that's okay too. Our patients or women with lung cancer don't have to be super women every day. It is okay to have a day full of Real Housewife. Pick the city you like. And old school, I like my Real Housewife in New Jersey. Everybody's different. Pick, pick a day of TV that not everything has to be a fight. Not everything has to be a documentary. You can see Teresa flip that table once again, even after you saw it 3 times. That's okay. Give permission and give yourself grace.
I love that, and I thank you for that, and I also love the New Jersey Housewives the most, so I'm biased. So you talked so much about vaginal dryness and mucous membrane dryness. Tell us some of your tricks and what do you advise your patients to kind of, I guess, cope with this or figure out how to make it work?
So there are 2 things we have to differentiate, the vulva and the vagina. So the vulva is the labia, the clitoris, and that dries out. And when the, hi Lisa, sorry, Lisa and our friends, sorry, hi Lisa. And when that dries out, there's 2 things. One, increases the chances of UTIs. When we have significant vulval dryness, increase the chances of UTI because the flora changes, so the bacteria is easier to go from the vagina to the urethra or the pee hole, right? So it's not only about intimacy, it's also about not having UTIs. There's nothing more uncomfortable than a UTI. That's what I told my male colleagues. If you haven't had a UTI, you don't get to talk about it. So, because there's nothing like that. So, vulva moisturizers help with the UTIs and also help with potential tears or making painful penetration. Because if everything is very dry, it's more chances that with the penetration, there will be tears outside and even abrasions against the labia. They're moisturizers. The moisturizers can be as coconut oil, yeah, the one you buy in Costco. Coconut oil with nothing added, please, not the fried coconut oil, the one that's a paste, the white one. The white one, organic, Trader Joe's, Costco. Organic, please, if possible. That will help moisturize if the vulva is very dry. If the vagina is dry, also increase the chances of UTIs, but it can make any type of self-play or intimacy painful, right? So those are lubricants. So moisturizers for the vulva, lubricants for the vagina, and those can be ideally water-based. But you can have fun too. You can have fun. I get a lot of samples in my clinic, so sometimes we have like watermelon, chocolate, and they can be good stimulators for oral sex too, right? It's like, hey, I just told my patient, hey, we have a watermelon shipment. Talk to the husband. That's the new flavor. So just normalize this. Normalize the lubricants. There are also lubricants with anesthesia or lidocaine. That helps in case you're having painful penetration because you haven't had penetration in a long time. Like I have this talk with patients like, oh, I haven't had sex in a year. Okay, right? We start little by little. You're not gonna go full on session when you haven't used it for a year. So the lubricants, and the lubricants can be bought anywhere. Most cancer centers have them. We do recommend water-based because if you're using condoms, but there are also other ones that are not water-based, they're silicone-based, they're also safe. But you need to make sure you rinse off very well afterwards. But vaginal dryness is a reality, and no, which cannot say that's the way. I think a lot of women society has told us that we need to suffer, we cannot say anything. No, we need to continue to propagate a life without vaginal dryness, if possible, right? There are many things out there that are possible, and a lot of these companies, you can actually email them and they will send you free samples. Like I always have samples.
Angela, can we put in the chat or Dr. Flores, can you at the end maybe send to Courtney some of these companies that are giving out free samples so our listeners can have access?
Most of them. Feel Good is very good. Astrogel is very good. I have zero COI with these people, no conflict of interest. The KI is very good as well. And you find it, have fun. Like, when you think I found this foundation in one attempt? No, it took me several attempts. So you need to find what lubricant works for you first. Partners are important, but partners are secondary in this discussion. And I'm going to continue to say that because sex is not a duty, it's for fun. And if you don't have fun doing it, because we have people that are asexual, then it's not for you. You can find fun in other things. And it's not a duty. It's not a duty, it's for fun. It's to make sure you do that. And that's what we started with body image, right? Because for women's sexuality, we have to feel comfortable with our body. Right? Another day, another time. But like the whole thing of trying to look or be something that we can affects our sexual capacity because you're so worried about the roll that's coming out when you're having sex that you don't have that much fun. You're worried about the roll, the wrinkle, the hair, that, oh, I didn't shave. I'm going to be graphic again. Audrey, invite me next year. No man has ever said, I'm not going to have sex because I didn't shave today. All right? So if you know one, let me know. But usually, no. So women were so reserved. It's like, oh, I haven't shaved today. I haven't showered in the 3 hours. No, let's go for it. In my opinion, of course. All of this is my opinion and it's very editorial.
Totally fine. I think you relate to the masses here. So you talked a lot about vaginal lubrication, and I'm sure this topic comes up quite a bit in your clinic as it comes up in mine about hormone therapy and using like estrogen gels and creams and other I guess sources of hormones that that can kind of help with this. How do you coach your patients and what do you advise?
So the first thing, I do have a cohort. I think around 10 to 15% of my patients are breast cancer survivors that unfortunately have lung cancer to the radiation field in which they go radiation for the breast cancer. And it's in part because my mentor is a breast cancer person, and as soon as that happens, they come to my clinic. So first thing, do you have a history of breast cancer? Yes or no? That's very important to dig. Many of our women had breast cancer history 20 years ago. So we cannot forget that because that's when the hormonal part becomes tricky. But that's the minority of patients. Vaginal estrogen is very little absorbed systemically. So I'm a big proponent of using vaginal estrogen. If that is, we always start with a regular lubricant, and if we need to step it up to vaginal estrogen, we can do that. The vaginal estrogen, if your oncologist doesn't feel comfortable, ask them to refer you to somebody who will feel comfortable. Every major cancer center has a sexual health department. Memorial has it, we have it, and a lot of these sexual therapists are actually providing virtual consults. Dr. Sharon Bover at Dana-Farber provides virtual consults. So you can be protected by the screen and they can do that. Your GYN also can provide the vaginal estrogen. When we talk about systemic hormones, that becomes more tricky because the data is very mixed. A lot of the data comes from the Women's Health Initiative study and for the vitamin study. And a lot of those studies were before targeted therapy and before immunotherapy. So the negative studies on lung cancer and hormonal therapy are when chemotherapy was the only choice. So I think for patients that have mutations in targeted therapy are more flexible about the use of low dose estrogen and progesterone. They have to be both supplements with the help of a GYN or a menopause specialist. Now we have primary care doctors that specialize in menopause. So you can literally go to the Menopause Society, put your zip code, and try to find a doctor close to you. So you don't get gaslighted about this is the change and you have to suck it up, right? Because there's a lot of menopause data now. It is a big change. And to anybody who hasn't watched the videos of Halle Berry about menopause, I highly recommend it. Because she talks about the reality of menopause. So imagine now menopause with steroids, which is menopause during chemo. All chemotherapy accelerates menopause. I have patients as young as 21 that are fully menopausal now because of the chemotherapy. So it's unfair to us that this 21-year-old will have no estrogen because she probably will have osteoporosis by age 40, right? Menopause is supposed to happen at time. So working with a menopause specialist doesn't have to be a GYN. It can be a primary care doctor that has interest on this. Low dose hormone supplementation and having a communication with your oncologist. But these hormones tend to be overall safe. At least there's other contraindications. It's hard to say for everybody, but I have patients on hormonal supplementation with the help of the menopause teen, and they're doing better because sometimes we're blaming it on the cancer drug. Everybody likes to blame everything on our drugs. And I was like, yeah, but this sounds like menopause. So let's figure it out. And you can measure the hormones and try to supplement it. Because let's all be very honest, estrogen is a beautiful thing. We have gotten this message that it's very dangerous and everything. Yeah, at the levels that we used to use, but it still has some benefits. So, very long answer to the question is you don't have to suck it up. There are solutions.
Oh, thank you. It's good to know that. And I think that may quiet a lot of nerves for some of our patients on the line that may have been told that they can't use their estrogen creams, for their Premarin or whatever have you. So just like Dr. Flores said, I would talk to your medical oncologist if you are on these creams, maybe see a menopausal specialist as she had suggested, get your hormones checked. Because you may not need to stop these medications, but each case is very different. So talk to your medical team.
For a world with moisturized vaginas. I should make a t-shirt, right, Lisa? We should make a t-shirt. Yeah.
I'll get that. I would love that. We need a pin.
Yeah, I don't know if the other day they asked me, you know, the picture I used of women covered in paint about lung cancer. I was giving a talk and they asked me to remove it. So I don't know if I can have a vagina pin.
Really?
Angela, write it down. Let's figure out what we can do.
So so on the topic of this, you did bring in that, intimacy starts with you, but it also involves a partner, whether that be a male partner, a female partner, whatever you prefer. Um, can you give us some phrases or how we can introduce the topic and advise our patients to sit down with their partners to really talk about this in an open way? What are some ways you suggest that we open up that conversation?
So some of the phrases that I ask my patients are mostly just coming from honesty. And as I know the last few months have been hard, we didn't expect. So you set out the stage. We didn't expect any of this to happen to our family. I'm learning how to feel comfortable with my new body, and I would like you to be part of this. That's how it starts. I don't know, I think being honest, how much I want or can do, but I would like to explore that with you. And that opens the door. Some of my patients, I told my patients, say that this is a new way, like when you started dating and you started having sex. You know, at the beginning, when you have a new partner, it's not the greatest sexual encounter you have the first few times. That has been proven by data. It takes a time to get used to each other, feel comfortable with each other. I'm gonna use something that my patient just told me this morning. It's like when you feel comfortable farting next to your husband, that's how you have to feel comfortable with your new cancer body, right? When you're able to pass gas next to your significant other, you know you have been there to the comfort level, right? So it's the same thing. Let's do it together if you're interested. And I also will be very clear. There are days in which I don't feel good. And these are my bad days. Day 7 of pemetrexed in carboplatin is very hard. The day before the scans, I don't sleep. My mom doesn't sleep. None of us sleep. The last thing I think a patient is thinking is about getting busy when your life can change based on the scans you're having tomorrow. So also talk about days that are not good days. But if you have a good PET scan, hey. And also aids, you can use it. I think we often think of porn about how it has been playing, but there are a lot of sites that are women oriented that has sexual content. Because a lot of the content out there, it actually minimizes and degrades the woman. So there are other sites for adult content that are more woman oriented that you can watch with your partner, or you can watch on your own, but you can watch with your partner to open that door to do something different. One of them is called Bellissima. I learned this from Dr. Bover. So these are, because women, we like stories, right? We like stories. So Dr. Bover said there's a whole story in every episode. So try, that could be an option. If it's not for you, you don't have to watch adult content. But sometimes it's a way to like open the door. But most importantly, say, this is new to me. I want to explore it with you. There are good days and bad days. Let's figure this out together. And that could be a good start.
I love that. I think that's so beautiful and honestly applicable for anything, whether you're ready to be intimate, whether it's about, feeling ready to, you know, do anything new in your life that you had put on pause at the start of your diagnosis and your treatment. So I love those words. I have been scribbling them down, so I'm going to steal
Um,
them.
and one other thing is that is also intimacy. Cuddling also, you secrete so much dopamine and serotonin when you cuddle that the same level that you will have sometimes when you go on a run. I don't run, I cuddle. So like cuddling is intimacy, holding hands is intimacy, scratching somebody's back is part of intimacy. So that's how it can start. It doesn't have to start with have full on lingerie. No, it's just a little cuddle, watching that show that you like or with your partner. Um, it is a way also of sexual health. And also stimulating each other without penetration is another way. There are many ways. It doesn't have to be anything. And I know it's the summer, but there's still times to cuddle here and there. And if you don't have a partner, you can cuddle with yourself too. And that's by loving yourself. I'm divorced now, engaged. And I can tell you the 4 years I was single, I cuddled with myself and I was fine.
Mhm.
Also, I have a cat, but my cat doesn't cuddle with me. She scratches me. So you can also cuddle with a pillow. It's just the sense of being comfort. It's so important. And if somebody gives you a hug, make sure the hug is at least 6 seconds, because that's when you secrete dopamine.
I love all of that, and I thank you. And I want to throw a little bit of a curveball here. I know we are focusing on women and lung cancer, and we will definitely go back to that, but there are some male listeners with us today, and they also struggle. And I'm just curious, off the top of your head, how do you advise these patients? Like, I definitely have patients in this space that have come to me and asked me about, intimacy in their lives, how they can deal with erectile dysfunction, how they can deal with, self-stimulation and how they can be the same partner that they were. So what are some things that you advise your male partners?
So there's two things. To the male partner is that you're not gonna break the woman. There's always a fear. The very dedicated husbands, partners, boyfriends are very worried that they will hurt the woman during sexual activity because they have cancer, they have radiation, and I like, you're not gonna break your wife. Your wife just pushed 3 of your babies. Believe me, you're not gonna break her. And they're like, okay, so just give the partner that permission makes a big difference. A lot of dedicated partners are very, very worried that they will hurt their partner. And are like, no, no, no. If your son who was 10 pounds went through that vaginal canal, you're gonna be okay. So just give them permission. For the patients that have sexual dysfunction and they're male, I think low testosterone is also something that we don't talk about it in oncology. And it's very important that it's addressed and treated if it's appropriately low. Okay, it has to be really low. No, no, not the commercial, like really low, by a urologist or endocrinologist, because low testosterone is also very common in treatments with chemotherapy. Also with steroids. A lot of our treatments require pre-medication with steroids, and that can affect testosterone levels. So having that measure is important because you can take Viagra, but if you don't have the libido, why is the erection for, right? So it's a mix of libido and function. So a lot of patients have more issues with libido than actually the erection itself. So when I ask my male patients about it, we ask, what is the issue? What is the problem? And sometimes it's not the erection of the libido, it's the shortness of breath because they had a surgery, because they had radiation. So find ways in sexual positions in which they don't require that much lung capacity. Women also have reduced lung capacity, but men in certain sex positions require a lot of lung capacity. So we try to find ways in which it's probable. And it's not always the women on top, because like the patient, the wife of my patient say, these knees are 62, Dr. Florez. I'm like, okay, I understand that. So we find ways to do that. So is the libido, is an erection, or is a shortness of breath due to the cancer treatments? So you get to address it either or then, because you can take Viagra, but if you don't feel to it, then that is not the solution. The erection is not the solution. It's the whole thing related to sexual health. And men also suffer for body dysmorphia. I just think women suffer more because we have to check so many boxes, but men also suffer from that. And my father's a urologist, so I'm gonna be honest with everybody. Sometimes I just call him and I say, hey, who should I send this? I need help. So he helps me too.
Well, you may be getting some calls from me to ask your dad. But thank you. And I think you're so right. I think men who, are experiencing difficulty in the bedroom, whether it's they can't get an erection because, physicality wise, there's an anatomical issue or mentally or libido, whatever it may be, I think the knee-jerk reaction is let's start someone on Viagra, let's start someone on Cialis, like let's go for the penile pump, like let's go really invasive, let's go to the injections. And that may be not right. We need to take a step back, like you said, and really ask the question instead of just throwing these pills at patients, like what really is the issue? And that's so important. I thank you for that.
And that the partner is okay with the other person having the stimulants too, because the woman needs to be okay too with that. So, and unfortunately, as our population is aging, there's a high probability that the partner may also have a different type of cancer or a different type of health condition that comes around.
Yeah, and also the side effects of these medications are not benign either. So it's really important that like you look into cardiac history and other things to make sure that they're fit enough to get this,
Yeah.
Oncogeriatric patients also have other comorbidities, like you said too. So we have to be careful for that specific population in general.
Yeah, but to have fun, you don't really need an erection. You can have fun in many different ways. And finding these creative ways is very fun. There are these dice that, who was this patient? 2 months ago, she brought these dice to clinic to show me that she bought on Amazon. And you throw the dice and tells you like, do this. So it's different ways to do it. Everybody has a different mood. Sex changes every day because you change what you want to do every day.
Very true. So you touched upon body image. I know we only have about 10 minutes left, so I want to leave time for Q&A, but I think it's really important to talk about, the use of these GLP-1 analogs, and how we're using them to help with weight gain from TKIs, but we're also using them to help with weight gain in general. Like, how do you utilize these in your clinic and how do you coach patients about them?
So I think they're a very good tool for the appropriate patients. Gaining weight with cancer treatment is becoming more the norm rather than the exception. So we do all know about ALK inhibitors. The median weight gain is 30 pounds. 30 pounds, 30, right? And that's the number one. But ROS inhibitors do that. We have to remember that MET inhibitors produce swelling more than weight gain. The weight gain from the ROS inhibitors and the ALK are rolls. It's fat. It's not like you're swollen. Because a lot of people think it's swollen. No, it's fat. You get the rolls. And then the people that are getting chemoimmunotherapy, the dexamethasone that you have to take prior to these treatments and after produces weight gain. I think my mom has gained approximately 35 pounds, 40 pounds, and this woman got 18 cycles of chemoimmunotherapy. No one or two, 18. So that weight gain is real. And the whole perception that diet and exercise is very important. It is very important because diet and exercise help you feel better, look better. But when you're taking a medication for the rest of your life that is going to constantly increase your weight, you need something more. I had a patient that came to my clinic, a young patient, and she was in a 500 to 900 calorie diet a day, and she was running and exercising because her drug was giving her weight gain, and her doctor's like, oh, you need to eat less. I'm like, no, this is the drug. So I use GLP-1 inhibitors with the assistance of the weight management clinic, the primary care doctor's office, they're becoming my besties on that, or the endocrinologist. I have tried to prescribe it. I would say I have been unsuccessful with insurance approval because they're still behind thinking that oncologists shouldn't be prescribing medications to lose weight because our patients supposed to be gaining weight. Most of my patients have weight gain instead of weight loss. There are the patients that lose weight, like my father lost like 40 something pounds. It was a head and neck cancer. So I tried to prescribe it first. If they told me no, then I go to the other. Sometimes I put the referral for the weight management clinic. The problem is the weight management clinic. Sometimes it's just book months in advance. So I think they're very good tools, used appropriately and monitored appropriately, because some of the side effects can be potentiated, right? So these medications delay the gastric emptying. So certain medications can, give worse side effects. So like alectinib, constipation, a GLP-1, constipation. So you want to make sure that those side effects that overlap between the drugs are also managed ahead of time, right? Reflux, very common with the steroids, very common with these pills. You want to make sure that is also addressed. So I do think we have a case series that we hope to publish soon about my own patients with ALK inhibitors and GLP-1, because the problem is I have a patient that gained 89 pounds. So what happens with that? That produces restriction in your lungs, right? You are lifting 89 pounds you didn't have before. That affects your self-esteem, affects how you breathe, affects your joints, increases the chances of diabetes, or you probably will develop diabetes. It worsens your blood pressure, affects your healing, affects your capacity of just staying active. So the weight gain associated with cancer treatment is a side effect of the cancer treatment. And like we treat NASHA, we need to treat that. And we need to stop telling women that they need to eat less and move more. We all know that. But when you have a drug that generally accumulates fat, I think it's very unfair. Sorry, I'm very passionate about this because we need to acknowledge that cancer treatments produce weight gain. That's the new cancer treatment. My mom is in a GLP-1 inhibitor. So
I totally agree. And I think there's only so much, compression stockings, elevate your lower extremities, exercise we can preach. I've definitely started using these in my clinic for various different reasons, and I think it's been very successful. The only thing to be mindful of is that they, like you had said, they cause delayed gastric emptying. So if you are going for a biopsy or some kind of procedure, there are certain guidelines that each institution has that you need to hold this medicine for at least a couple days before the procedure, sometimes up to a week. So that's just something to keep in mind going forward.
And a lot of primary care doctors can prescribe these drugs. And the new indications, some of the initial indications for these drugs was diabetes, but they're evolving and now includes weight gain. And obesity is a disease.
Yes.
Like blood pressure.
We have 5 minutes left. If anybody has any questions, feel free to pop them in the chat. Otherwise, we can move on to some other topics, and as these questions come up, we can kind of call upon them, maybe. What do you think?
And you know, every event we always have questions afterwards, so you always can email the team, and we always can. It just Lise and I just talk a lot.
It's true. I can always just text Dr. Flores and just let her know that questions came up or go from there. I did mention your grandma's treatments that I think are so helpful. And if you could just share some of those tidbits with us. I know patients are always asking, is there anything that you could advise that maybe I don't need to pick up, as a prescription that can help me with various things, nausea, with my, my nails, my paronychia. Um,
Hi,
oh,
Rosemary. Sorry, I just had to give a shout out to Rosemary. Hi Mo, I just saw you. I didn't see you before. Hi Mo. So the nails, TKIs and nails are very bad. 1 cup of vinegar, 1 cup of water, sucking on your nails for 15 minutes has a significant change in your nails, because what happens is the nails have bacteria overgrowth in the nails due to the drugs. So the vinegar just works as a bacteriostatic to prevent the hyper growth of the bacteria to damage the nails. Also, what to use for your nails. It's recommended that you don't use acrylics. Those are the ones that are put on because it will weaken the nail underneath. But you can use gel as soon as you put sunscreen. Because if you're in a TKI and you put your nails underneath the lamp, it can flare rashes. But if you put sunscreen, it's safe. Another thing that really has helped my patients is coconut oil for hair. I don't know how many of people here have gotten paclitaxel or chemotherapy that loses their hair. The hair that comes back is a wild hair. It's gray, thick, and curly. I have patients that have straight hair, black, and they lose their hair with chemo and comes back that. So coconut oil is very, very good. Every patient who is in cancer treatment is a higher risk for sunburns. So right now, we're in the summer. Sunscreen is key. Sometimes you may feel very sticky. So there are some of these shirts that also have sun protection that are long sleeve that you can put it on. Bye, Lisa. That you can put it on for that. Other things that make sure the makeup that you have. What was the coconut oil for? Well, the coconut oil is good for vulva moisturizing. It's good for your hair. It's good for your legs, and is actually even also good as a moisturizer as a whole. Oh,
there's a question up. I don't know if you saw
yeah.
the dose of the estrogen cream and also the name of the menopause videos.
Okay, I'm gonna put the menopause videos in the chat. The estrogen cream will depend on every patient for the dose, but the dose tends to be a standard. Let me put the menopause videos. There's a lot of grandma recipes that really work. Something that works for swelling is pineapple. And pineapple also works for sometimes your vaginal secretions may have a sour taste because of the chemotherapy. What you taste in your mouth, when you're having chemotherapy and the food tastes very metallic, the vaginal area will have similar taste. So pineapple juice tend to help the secretions kind of lose some of that sour taste. Of course, you have lubricants with flavor, but that can help that. How often the vinegars, I usually recommend 3 times a week. And you can use the Sense Ziploc bag. I have a patient that has been using the Sense Ziploc bag for 3 years. She's just committed, not because she doesn't want to buy them. She's like, I see how many times. And the vinegar can be for the Dollar Tree. It doesn't have to be any fancy or like Dollar Tree gallon vinegar, white vinegar, the one that's used for cleaning. Other things, we were talking about pineapple. Pineapple juice also has natural diuretic that it doesn't interact with you. As soon as you don't start drinking, 7 liters of pineapple juice, I don't think nobody can do it, but there's nothing more stronger than a woman that's committed. But pineapple juice also can help with swelling. So it's a natural way of doing that. I need to write all these grandma recipes eventually. So the patients that are in MET inhibitors or immunotherapy, they tend to get swelling underneath their eyes or amivantamab. They get swelling. So after you have drink chamomile tea, and you have the tea bags, put it in the fridge and put it in your eyes. That has significantly anti-inflammatory capabilities. I'm trying to spill the grandma recipes. There's so many. Do you struggle drinking water? Now I'm sounding like an infomercial. Do you struggle wrinkle your clothes? If you use, I don't like drinking water. I'm being very honest, and I'm very honest with my patients. So cucumber has the capacity of adding electrolytes to the water naturally, and it provides hydration that's better than pure water. So cucumber, you can put a few slices of cucumber and just make me feel like you're in a spa. I don't know if you ever been in a call with me. I have my cucumber water and people think I'm having a mojito at 9:30 in the morning. No, it's because I struggle drinking water. I have a chlorine disorder, so I need to drink water and I struggle. So I put cucumber, who brings electrolytes to the water and actually helps with some diuretic capabilities. So there's a lot of things. Just make sure you talk to your doctor to make sure there's some things that are not unsafe. And acupuncture is also very, very helpful for nausea control, for neuropathy. It can be very, very helpful. And my last grandma recipe for is nausea. We often think, I have taken a lot of Sofran in my life because my medical conditions, and that constipation that Sofran gives you and those headaches are a piece of work. But sometimes the nausea is not that bad. So what can you do? Ginger. Ginger, a good ginger is key for nausea control. Ginger chews, ginger candy, ginger tea, or candy ginger. And that when you feel like, we all know when you're getting nauseous, your mouth starts getting watery, starts tasting funny, just pop a little ginger. Remember, our grandparents always had candy in their pockets. That was my grandpa. He always had candy. So ginger can really help you without getting to the suffering. Peppermint essential oil. Not to drink it. Not to drink it. That burns the food pipe. But peppermint essential oil in your wrist can help you with that mild nausea, so you don't have to take the Sofran. And because Sofran comes with that constipation and that headaches, I get awful headaches with Sofran. So that's a little bit of the recipes. I'm gonna look at the videos, but I promise Angela makes me accountable. Angela makes me accountable. I'm gonna write all these recipes in one document in the next month, and I will share it with people. Because I keep talking about my recipes and I never put them down. And all of these recipes come from patients. Like witch hazel, if you have very itchy skin with immunotherapy, if you don't want to use the hydrocortisone because it makes the skin drier and more thin, witch hazel helps with that itching. So all those little things that as a community we have learned from each other, we need to put in writing. And that's on me that I haven't done it. It's fully on me. Let's look for Halle Berry.
We look forward to that document. I will be printing that and slapping that on the wall in my clinic for sure. And also giving it out to our nurses so that they can help educate others. We are actually over time though. So I know I could never stop talking to you. Please, we could go all night. But I want to be mindful of the others that are on this call. And oh, thank you so much for putting that video in there, that link. And maybe Courtney, we could make that available on the website for those that weren't able to join.
He has a master class, but you have to pay for it. So don't pay for the master class. It's very expensive. So just being honest, just being honest.
Well, I think we probably should bid adieu. Do you have any closing remarks that you want to leave with these incredible people that joined us today?
Is that for me? Sorry.
Yeah, that's okay.
Oh, sorry, I was looking at Halle Berry.
That's okay, don't worry.
The main thing is that every patient's experience is very different with cancer. And you have the grace to make the experience what works for you. You don't have to be a superwoman every day. That toxic positivity that we see in social media, I think it can be harmful because my women, I don't call my patients, call them my women, feel like every day they need to go, go, go. No, there's Sundays, which is okay to just watch the Real Housewives or whatever no thinking TV show you want. It is okay. That's my take home message.
Thank you. And thank you for joining, everybody. Really, can't wait to check out those videos myself. And Dr. Flores, really, I thank you for all your insight. All right, take care. Bye, guys.